ஆன் பண்ணிக்கோங்க. உட்கார்ந்து ஆன் பண்ணிக்கோங்க வீடியோவை.
உள்ள அந்த ஏசி சுவிட்ச் மட்டும் மெயின் சுவிட்ச் மட்டும் ஆஃப் பண்ணுங்க. சரியா? பாத்துக்கோங்க கண்ணுங்களா, ஏதாவது நான் ஃபோன் பண்ணுங்க. இதை மட்டும் போட்டோ எடுத்து அனுப்பிச்சுடு.
யாருல ஒரே சத்தம் வருது? யாருல இவ்வளவு நாய்ஸ்? ஜனனி ஆரம்பிக்கிறியா? மேடம் இருந்தாச்சு.
கொஞ்சம் தயவுசெய்து ஒரு நிமிஷம் வந்து எனக்கு இங்க உள்ள செட் பண்ணி உள்ள போனா அது சாரி என்ன பண்ணணும்னு சொல்லிட்டு நான் பண்ண கையில ஹலோ. சரி அவங்க கால் பண்ணாங்களா?
மியூட் பண்ணிக்கோ.
கனெக்ட் பண்ணி தான் இருக்கு. நீங்க எந்த பிரிண்டர்ல சூஸ் பண்ணிருக்கீங்க?
Madam, I'll unmute you, madam. Madam, you have to unmute yourself. Unmute பண்ணு. Okay.
Hello, கேக்குதா மேம்?
கேக்குது மேடம்.
Madam, sorry, I got it. Good afternoon to everybody. Good afternoon, ma'am. Start பண்ணலாம்.
என்னோட வாய்ஸ் கேக்குறதா?
Yes, கேக்குது மேம்.
Okay. சரி. நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்பரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனர் திருநாளும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Hello.
Yes, madam.
Very good afternoon to everybody. Welcome to this afternoon meeting in Zoom. I welcome all the person who joined in the Zoom meeting, and I welcome both the speakers, and I welcome the Secretary Dr. Kanakvel, and welcome the Treasurer Dr. Mrs. Mangai, and the Vice President Dr. Saravanan, and everybody. We'll go to the program. We'll start our sessions. Welcome once again.
Secretary's report.
I thank the faculty of today's CME Dr. Namita ma'am, Professor of Internal Medicine, Stanley Medical College. Professor Jayalakshmi ma'am, Professor of Nephrology, Super Speciality Hospital, Tamil Nadu Government, Omadurar Estate. Our President, Dr. Vedakumari ma'am, our State Office Bearers, Dr. Saravanan sir, Dr. Shanta ma'am, Dr. Maragadamani ma'am, and all our other delegates for attending today's session. The CME, which was held in October on the 8th of 2022, covered topics of surgical procedures and family practice by Dr. Saravanan sir, adolescent mental health by Dr. Janani, PPLSS schemes of IMA by Dr. Bhupati John, which was funded by Linex Pharma. We thank them for the same. This was held in Girishwari Hospital on the 8th of October. The previous month's CME, which was held on November 12th, 2022, was in lieu of World Diabetes Day, which had very eminent speakers like Dr. Suguneshwari Ganeshan ma'am, Senior Consultant Vitreoretinal Surgery of Shankar Nethralaya, and she spoke on the myths and the facts of diabetic eye diseases. Dr. L. Sriram sir, Senior Diabetologist and Physician of VHS Hospital, who spoke on insulin initiation and titration in a new diabetic patient. This was held as a Zoom meeting. Last month, we also saw that the FSS claim for Dr. Colonel Ranganathan had been handed over to his wife, Mrs. Maithili, for 18 lakhs. 7,000 patients were screened by Udi Eye Hospital as a free eye camp. As a part of spreading awareness about substance abuse, varying school activities were taken place by Dr. Shanta ma'am, along with Dr. Janani, and a lot of talks were given in various schools in and around Mylapore. We have now forwarded an application for a new member. We have 4 NHP renewals and 3 FSS enrollments. I'm also very proud to announce that we have several award winners from our branch, including Dr. Saravanan sir, Dr. Vaibhav sir, Dr. Shanta ma'am, Dr. Maragadamani ma'am, Dr. Kanagavel sir, Dr. Mangai ma'am, Dr. Lavanya ma'am, and Dr. Janani. And 5 awards for our branch. And all of this is to be held on the 17th of December 2022, starting at 11 a.m. in Chennai Trade Center, Nandampakam, during the 77th Annual State Conference IMA, Tamil Nadu, Timakon. Dr. Kanagavel sir has been selected for the National President's Appreciation Award for the year 2021 and 22, which will be conferred upon sir during the IMA NatCon 2022 to be held at Pragyaraj, Allahabad, Uttar Pradesh on December 26th to 28th, 2022. Nominations are hereby called for the election of office bearers for the year 2023 for posts of Vice President, Secretary, Joint Secretary, Assistant Secretaries, Executive Committee members, which should be sent to the Honorable Secretary before the 24th of December 2022. Members can also apply for posts of State Council and or Central Council members. Members occupying any posts currently and those who wish to continue can also submit nomination forms. Our next meeting, which will be held on the 21st of January 23, Saturday, as a lunch meeting at Raj Palace, Srinagar, will see a CME followed by the installation of the new office bearers. Our next annual general body meeting will be held in Girishwari Hospital on the 30th of December at 3 p.m. Thank you. I hereby open the stage up for any of the delegates who would like to comment.
Good afternoon. This is Dr. Saravanan. Yep. Good afternoon to everybody. President, I would like to know, is there any nomination forms you got, or the secretary or Janani got any nomination forms from the members, or still the same office bearers continuing as office bearers for 23 also? Is there any new form you received?
No, sir. None so far, sir.
None so far.
But I'll have to check with Kanagdale, sir. None so far.
Okay. So we have to. Probably we have to.
Sir?
Shanta madam, do you have anything in your mind?
Yes, sir. Already those who are in post, are they going to continue?
No, if there is no other competition, then we have to continue as the same office bearers. But what about the vice president, president-elect, and all that?
Is Rukmani going to take up the president post, sir? Did she say anything?
Madam, Rukmani is there.
Rukmani, madam.
Rukmani is there.
Dr. Rukmani?
Hello.
Yes.
Can you hear?
Yes, madam.
Yes, ma'am. Yes.
Because I know internet, I have no idea whether I'm heard or not.
நீங்க போஸ்ட் நீங்க பிரசிடென்ட் போஸ்ட் வரலா?
Am I heard? I'm heard.
Yes, madam. சொல்லுங்க.
இல்ல வேற யாரும் இல்லனா I'll take it up. No problem.
வேற யாரும் இல்லன்னு இல்ல. Automatically you will be you are the next person, no?
சரி, okay. Okay, done.
நீங்க நாமினேஷன் போட்டுடுங்க பின்ன.
Kindly submit the nomination forms.
Okay.
And those who would like to continue as the same post also should give a nomination form, ma'am.
Okay, okay.
Everybody, when is the last date, Dr. Janani?
24th.
24th, sir. 24th of December.
24th.
Too late இல்ல?
It's not too late. We can.
Sure.
Sir, I have one question. Why from our branch, Dr. Suresh name was nominated for any awards from the state or because he has found one rare disease and everybody has acknowledged, even Sendamil Pari has acknowledged this thing and he has given 20 minutes time. இதுல நம்ம பிரான்ச்ல இருந்து ஏன் அவருக்கு ஸ்டேட் அவார்டுக்கு வாங்க கொடுக்கல? ஏன்னா இந்த இத்தனை அவார்ட்ஸ் வந்திருக்கே.
I've included this name yesterday, but see, the awards are given only to the persons who are contributing to the association, not the individual. Whether he can be an academician, but
அப்படியா?
association
இல்ல, but he is
contribution
from
must be there.
இல்ல, but he is from our branch, no? We should recognize his இது இல்லையா?
I've included him yesterday. No problem, don't worry.
But okay, sorry. Thank you, sir.
The contribution, we expect some contribution to the association. That is where we give. Generally, individual, there are a lot of people who are doing researches and so many academic events now they are conducting. But that is the reason. But anyway, I've included this name yesterday. We'll see. They are analyzing it. We will get to know about this on Monday.
Okay, sir. Thank you, sir.
I am continuing as EC member.
Okay, sir. Okay, sir. So please give the nomination form before 24th of this month.
Yes.
Yes, sir.
Yeah. You can even send a mail also, or what are the other ways of giving a nomination form, Dr. Janani?
Janani?
Sir, good afternoon.
Good afternoon.
Good afternoon.
Sorry, I have to quickly wrap up. Sir, the nominations can be sent by mail or by post. Any form is accepted, but it should be complete in all blanks. There should not be any empty blanks. Unsigned and incomplete forms will be rejected. That's the only concern. Otherwise, I request all of you to do not wait till the last date. Yes, sir. Do not wait till the last date. That's why we gave such a long thing before AGM. We have to finalize. The other thing is, I would also like to tell that coming Tuesday, 13th, we'll have the final EC meeting for the year at Girishwari Hospital at 3 p.m. Thus, the information will also shortly be shared in the group of the EC members. So these are the information at this point of time. So Dr. Shankari has applied for the State Council membership through email, but again, that was incomplete. So I've written the form back to her. She promised to send a signed copy of the form. So as of now, I'm yet to receive any new nominations or continuation nominations also. So I request all the members to speed up and send the filled up forms at the earliest possible time. Thank you very much.
Okay.
Can we deliver it in person also?
Yes, sir. It can be given to the secretariat at Girishwari Hospital, sir. Any format is accepted.
Girishwari Hospital, yeah.
Yes.
Okay, okay. Anything else, ma'am?
Any member would like to share any information or any message? Any comments?
Sir, when is the full body meeting?
Dr. Suresh Kumar lecture was supported by us only.
Yes,
So I think Harunan sir has also spoken to Pari sir and we have requested. On that note only, on our request, Pari sir has kindly accepted Suresh Kumar sir's paper. And I'm sure, I think Dr. Saravanan has explained regarding the award issue, but anyway, he'll be a special case for this. And I will also recommend and request on behalf of the state president, Dr. Palaniswamy sir, to register all of you for the Timakan event, because it is happening in Chennai and we have to support the state conference. I request all of you to register and take active part in that. And more so, I invite all the members and the office bearers to collect the awards on the IMA Chennai South behalf. It is everybody's contribution. Every single member and every single office bearer has contributed for the benefit and awards, whatever we have received. On behalf of all of us, I thank the state president and the North Zone Vice President, sir, for facilitating all these awards. In fact, I should put on record, Vedakumari ma'am has been kind enough. She extended full support. He was just telling, please do the program on time and please send the invites on time. That's the only thing she has been insisting on me, and she gave full freedom for me to work on. Also, the national president, Dr. Sahajanand Prasad, has sent the invitation for the national conferences to be held at Allahabad, 26, 27, 28. And he has requested this message to be given to all the members to be there for the gala event at Allahabad. And Allahabad is a very spiritual place. Many people should be knowing it. It is about 1.5 hours drive from Varanasi. And it has many spiritual circles. Those who are interested should plan their trip now. So with this, I think I will hand over back to Janani, and I'm sorry I could not continue to stay with us because of my other academic commitments. Thank you very much. Dr. Janani, please take over.
Yes, sir.
And also I request all the award winners to register and participate in person. There's no proxy allowed. So kindly register yourself, because before 10th, it is only 4,000 rupees. After 10th, for the Timakan event.
Today is the last day, sir.
Today
Today is the last day.
Yeah. So kindly register even before 6 also, it's not a problem. Kindly register and come in person to receive the awards. Thank you. Thank you very much.
Thank you.
Ma'am,
Jeremy,
may I
can
continue?
take up.
Yes, thank you, sir. Thank you, everybody. I have the honor of introducing our first speaker for today, Dr. Namita Narayanan ma'am, who's an MD in internal medicine, who's currently the Associate Professor, Department of General Medicine, Government Stanley Medical College, Chennai. She's been an invited speaker in TAPICON 2021 at Maher Faculty Development Program, Faculty MU, Government Stanley Medical College. She's a member expert committee on poisoning management, Government of Tamil Nadu. She's published several articles in prestigious medical journals and completed an advanced course in medical education. She's conducted various intra and inter-college quiz competitions. She's also conducted a state-level inter-college quiz competition in TAPICON 2017. Her field of interests is mainly in critical care medicine, emergency medicine, toxicology, and medical education. Welcome, ma'am. Thank you so much for accepting our offer today. We're looking forward to listening to you.
Thank you very much, ma'am, for the kind introduction. Am I audible?
Yes.
Yes, ma'am.
Can I start sharing my slides, ma'am?
Yes, ma'am.
Yes, ma'am. Welcome, ma'am. Welcome.
Yes, ma'am.
One second, ma'am, as we get set up. At the outset, I would like to thank the organizers, especially Dr. Kanakben, my good friend and classmate, Dr. Mangai, Dr. Saranan, and YBK madam for this opportunity.
Your slides are seen, Dr. Namita. Make it full screen and please.
Okay, that's what I'm trying to do.
Press F5, ma.
Yeah, one second. Is it visible, Kanakben? Is it visible now?
Perfect. Good luck.
Yeah. Thank you very much once again. My topic given to me is evaluation of anemia in adults. So in the given 20 minutes, I hope I can do justice for this topic. So as we all know, anemia is one of the most common problems encountered in clinical practice. All of us see day in and day out. It is defined as a reduction in one or more of the major RBC measurements. And it can either be a low hemoglobin or a low hematocrit, which are the most widely used parameters. So what is the WHO definition? WHO definition goes like hemoglobin less than 13 in adult males and less than 12 grams per deciliter in adult females. But we cannot stick on to these measurements because we have so many adults who are healthy with otherwise low hemoglobin. So how do we approach the diagnosis? Based on the clinical features, medications and underlying conditions, and some flags on initial complete blood count and chemistry panel of other cytopenias, RBC size, whether it is small or big, microcytic or macrocytic, and the bone marrow functioning appropriately. So moving on to the symptoms, whether it is acute or chronic. It could be an acute blood loss or a chronic blood loss, history of malabsorption, history of chronic diseases and inflammatory disorders, history of malabsorption syndromes, and also other history of medication, family history, people with a strong family history of sickle cell, hemolytic anemia, thalassemia, especially in areas of Kerala and other western parts, dietary practices, infections and infestations, and symptoms suggestive of hemolysis as seen in high-colored urine, jaundice, history of gallstones, and also other symptoms suggestive of liver disease and renal disease. So how do we evaluate an anemia? It can be of two types based on the clinical presentations and based on the lab parameters, complete blood count and the retic count, which forms the cornerstone in any evaluation of anemia. Coming to the clinical presentation, as I said, acute blood loss is one of the major causes of anemia. It could be trauma causing blood loss, or when it is quite challenging when we have a cause of blood loss which is occult, as seen in GI malignancies where you have to go and do a stool occult blood. So in evaluating a case of acute blood loss, we need to do the coagulation studies and also the assessment of other bleeding disorders to rule out any other congenital problems. So another history that we would like to have is a strong family history, which indicates a strong family history of hemolysis. Episodic hemolysis is seen in G6PD deficiency. And what would be the lab findings that would help us to say that it is a hemolytic anemia? Like you have a decreased RBC count with a high retic count and a high LDH and an indirect bilirubin, and also acholiuric jaundice, low haptoglobin, direct antiglobulin test, and a peripheral smear pinching the diagnosis of hemolysis. So what are the medications, history of medications, which patients, most of our patients are on a battery of medications, so we need to ask them what medications they are on when we are evaluating an anemia. For example, aspirin, steroids, and NSAIDs, they can cause GI mucosal irritation and cause an iron deficiency anemia. And PPIs, which we right, left, and center, H2 receptor blockers, antacids, all these can cause vitamin B12 deficiency and thereby anemia. And metformin can cause an altered calcium hemostasis and thereby causing a vitamin B12 deficiency. And nitrous oxide again causes inactivation and a vitamin B12 deficiency. We all know that methotrexate can interfere with folate deficiency, requires supplement folic acid along with methotrexate. So that is again another cause of folate deficiency and anemia. And we have our anti-seizure medications like phenytoin and valproate, which can also cause folate deficiency. And hemolytic anemias can be caused by antibiotics, anti-cancer drugs, and drugs like lorazepam, which is immune mediated, and antibiotics like chromactin and dapsone can cause an oxidative stress and thereby cause anemia. Thrombotic microangiopathies can be seen with decline and chemotherapy, and impaired bone marrow function can be seen with hydroxyurea, chemotherapeutic agents, and sideroblastic anemia with iron. So the detailed history of medications is essential in a patient with anemia. Moving on to the clinical features, symptoms can be vague symptoms of fatigue, tiredness, and breathlessness. And also, when the anemia is severe, they can go on with shortness of breath, especially on exertion, and heart failure, symptoms suggestive of heart failure. So symptoms on general examination, we can have a pale mucosa, angular glossitis, and cheilitis as seen in the picture here. And you can have nail changes like koilonychia or spoon-shaped nails as seen in iron deficiency anemias. Skin can be cold to touch. There can be tachycardia and tachypnea also in patients with anemia. And per abdominal examination can show a hepatomegaly, enlarged liver size, or a splenomegaly, which will give us a clue whether it is any infiltrations or any malignancies causing anemia. CVS, as I said, the patient can present to us with a high output cardiac failure. And in CVS examination and the B12 deficiency per se, you can have a peripheral neuropathy like fissure and also the impaired proprioception and impaired vibration sense. So all these are features of or symptoms and signs of anemia per se. And how are we going to evaluate a patient with anemia based on the complete blood count? The complete blood count will be the cornerstone. Along with complete blood count, the reticulocyte count also needs to be done. This is just an overview which shows that index of less than 2.5 and with an index of more than 2.5, reticulocyte index. So if the index is less than 2.5 with a red cell morphology of normal red cell morphology, we need to know whether it is a hyperproliferative disorders as seen in marrow damage, infiltration fibrosis, and iron deficiency. Or if it is micro or macrocytic, whether there is a maturation disorder. If the index is more than 2.5, then we list of causes of hemolysis or hemorrhage, as seen in blood loss, intravascular hemolysis, metabolic defect, membrane abnormalities, and the N number of hemoglobinopathies. So what are the laboratory tests which help us in the diagnosis of anemia? The red cell count per se, the hemoglobin, the hematocrit, and the reticulocyte count. The red cell indices like the mean corpuscular volume and the mean corpuscular hemoglobin, and also the mean corpuscular hemoglobin concentration and the red cell distribution width. Do the WBC count also help us? Yes, whether it is normal or increased or decreased, whether it's an isolated anemia or an anemia associated with all the other cell lines. The count is also important. And last but not the least, the peripheral smear, which shows the cell morphology, the size, the hemoglobin content, any increase or decrease in size of the RBC, anisocytosis, and also whether there is any falling off the RBC with anemia. All these are clues which will help us in the diagnosis of anemia with a CBC. So what is hematocrit? Hematocrit is nothing but the fat cell volume or the percentage of blood volume containing the RBC. This is a component of the blood, and it is calculated value depends on two parameters. One is the size of the RBCs and two is the number of RBCs. A thumb rule is to remember the rule of 3. That is the RBC in millions into 3 will be the hemoglobin, and hemoglobin into 3 will be the fat cell volume. If there is any dysmorphism in this, we know that we are dealing with either a microcytic anemia or a macrocytic anemia. So the indices, the definition of the indices, mean cell volume or mean corpuscular volume is nothing but hematocrit into 10 divided by the red cell count. So the normal volume values being 80 to 100 picoliters. What is mean cell hemoglobin and mean corpuscular hemoglobin? That is hemoglobin into 10 divided by the red cell count into 10 to the power of 6. The normal values being 28 to 34 picograms. And MCH hemoglobin into 10 divided by MCH by MCD. Normal being 30 to 36. More than 36, we know we are dealing with hereditary spherocytosis. And red cell distribution width is nothing but the coefficient variation of the MCD. All these are calculated automatically, and we do have all these indices in our normal test that we do. It gives us a volume of information. And what is reticulocyte count? It represents the erythropoietic activity. Reticulocytes are red cells that have been recently released from the bone marrow. So they are just the premature RBC. And if they are more in number, we know that the bone marrow is proliferated. And reticulocyte percentage is multiplied by the ratio of the patient's hematocrit to the expected hematocrit for the age and sex of the patient. So again, what all, as I said, peripheral blood smear will be the cornerstone for any diagnosis of anemia. So what all can we see in a peripheral blood smear? Defects in red cell production, anisocytosis which correlates with the increase in the red cell distribution width, poikilocytosis which suggests a defect in the maturation and cell precursors in the bone marrow or fragmentation of the red cells, and nucleated red cells, Hobel-Jolly bodies, target cells, Hobel-Jolly bodies, and patients with splenectomy. So all these can be seen in peripheral smear. So I'll show you a picture of a normal peripheral smear. Here you can see that there is a central pallor, which indicates the appropriate appearance of red blood cells with a zone of central pallor which occupies about 1/3 of the size of the RBC. So this is a normal peripheral smear picture. And this is a picture of an iron deficiency anemia. You can see the red cell size is decreased and an increase in the pallor. So both are indicative of microcytic and hypochromic anemia. So in an iron deficiency anemia, we have low hemoglobin and hematocrit, decreased iron stores and low serum iron and ferritin. Red cell numbers are decreased and are microcytic and hypochromic. They are irregular in shape as evident by poikilocytosis. The sizes are irregular as evident by the anisocytosis. And you also have a reduced MCHC and MCD. And the membrane changes might predispose to hemolysis. So how do we differentiate this from thalassemia? Thalassemia, we have the serum iron and ferritin, which is normal, though it is microcytic hypochromic. We have normal values of serum iron and ferritin. So based on the morphology of the red blood cells, we will classify anemia as either microcytic, normocytic, or macrocytic. Microcytic is when the MCV is less than 80. Normocytic is when it is 80 to 100. And macrocytic is when it is more than 100. So what are the examples of microcytic anemia? As I said, it could be iron deficiency, thalassemias, copper deficiency, and sideroblastic. And sometimes anemias of chronic disease. Normocytic, what would be the examples? It could either be, we classify them into hemolytic or non-hemolytic. Hemolytic can be any hemoglobinopathies like thalassemias, hereditary spherocytosis, and all of them. It can be enzyme deficiencies. It can be autoimmune hemolytic anemias. It can be macroangiopathic or microangiopathic hemolytic anemias and any infections causing hemolysis like malaria. And then non-hemolytic can be aplastic anemias, iron deficiency anemias in the early stages, or anemia of chronic disease in the early stages can be normocytic, and acute blood loss can also be a normocytic normochromic anemia. So what are the examples of macrocytic? Macrocytic, again, we classify them as megaloblastic and non-megaloblastic. Megaloblastic is nothing but where the DNA synthesis is impaired, and we have hypersegmented neutrophils. The size will be more than 120. Whereas in non-megaloblastic, the DNA synthesis is normal, and the MCV size is between 100 to 110. So what are the examples of megaloblastic? All of us know it is the vitamin B12 deficiency and folate deficiencies. We have myelodysplastic syndromes, Fanconi's anemias, and time and responsive megaloblastic anemia. Non-megaloblastic macrocytic will be all our day-to-day diseases like hypothyroidism and liver disease, and also alcohol can cause non-megaloblastic anemias, multiple myelomas, and Down syndrome. So with microcytic and the Reti index, how are we going to classify them? Microcytic anemia with lower normal Reti index would be iron deficiency anemia, sideroblastic anemia, whereas with the increased reticulocyte count, we know it would be the hemolytic anemias like thalassemia. Normocytic anemias with a lower normal Reti index, we have the iron deficiency, anemia of chronic diseases, bone marrow suppression like casein, and aplastic anemias, chronic renal insufficiency, hypothyroidism in the early stages, and copper deficiency. And with the normocytic anemia with increased Reti count would be hemolysis or bleeding or bone marrow recovering from the folate replacement. Macrocytic with again normal or low Reti index will be a vitamin B12 or folate deficiency, excessive alcohol, MDS, liver disease, hypothyroidism, and HIV infections. And whereas with an increased Reti count would be a hemolysis with the bone marrow recovery. So how do we calculate? We have something called as absolute reticulocyte count and corrected Reti count, and not delving into the details. These are pictures of hemolytic anemias. I'll show you better pictures. This is a peripheral smear picture showing the sickle cell here. I think all of you can see the sickle cells here. And this is the picture of a thalassemia. This is a nucleated RBC with a hyperchromatic cell and a target cell. And this again is a picture of thalassemia with a target cell. So hereditary spherocytosis, there you don't have the central pallor at all. So these are the spherocytic cells which are seen in the peripheral pictures, smear pictures. So all these are clues for us to in the evaluation of anemia. And this is a microangiopathic hemolytic anemia which shows the fragmented RBCs. As you can see here, these are the fragmented RBCs here, which again will give us a clue of again thrombotic thrombocytopenic purpura or hemolytic uremic syndromes. So this is the megaloblastic anemia, which are bigger size of the RBCs with the hypersegmented neutrophils. You can see the large oval RBCs in comparison with the normal peripheral smear picture in this slide. So what are this? We've all now discussed only about anemia. Now, what if the RBCs are decreased along with the WBCs and platelets? So causes of pancytopenia, it can either be congenital or acquired causes of pancytopenia. Congenital examples would be Fanconi's and HLH and GATA2 deficiency or Viscout-Alvord syndrome. Acquired can be any number of causes. Again, we divide into whether there is a bone marrow infiltration, whether there is a bone marrow failure, or there is a sequestration of the cell line. So bone marrow infiltration, we know it can either be malignant or non-malignant. Non-malignant could be myelofibrosis or tuberculosis. Malignant could be any leukemias like acute or chronic leukemias, myelodysplastic syndromes, or multiple myelomas and metastatic cancer. Where do you have the bone marrow failure with a pancytopenia? It could be either be immune destruction or nutritional or bone marrow suppression. Bone marrow suppression, as seen as some infections like viral infections and EBV. Nutrition, we've already discussed the megaloblastic, excessive alcohol, copper deficiency, zinc toxicity. And immune destruction can be aplastic anemia and large granular lymphocytic leukemia, autoimmune disorders, and HIV. Where do we have the destruction or sequestration or redistribution? It could either be in DIC, as we see in consumptive coagulopathy, and causes of splenomegaly. It could be portal hypertension, it could be autoimmune disorders, or it could be even SLE or rheumatoid arthritis causing the destruction or sequestration and redistribution. And what are the causes of aplastic anemia? It was mostly acquired. It could be any drugs, cytotoxic drugs and radiation. It could be some toxic chemicals. It could be viral infections. It could be drugs, mainly being antibiotics like sulfonamides and chloramphenicol. It could be phenylbutazone, anti-thyroid medications, and sometimes arsenic. All these are examples of aplastic anemia. So now summing up, so how do we evaluate a patient with anemia? So we basically see the mean corpuscular volume or the MCV. If MCV is less than 80, what are the causes? It could either be iron deficiency anemia, thalassemia, or anemia of chronic disease. So if in this picture, we do a low, we see do a serum iron and ferritin. And if it is low ferritin or the TSAT, that is the transferrin saturation is normal, low, then we know it is iron deficiency anemia. If it is normal, we know it is a thalassemia. So hemoglobin analysis or the hemoglobin electrophoresis is necessary then. And if the MCV is normal, that is 80 to 100, we have n number of causes. It could be early stages of iron deficiency, or it could be anemia of chronic diseases, or it could be liver diseases. And if it is MCV is more than 100, we know it could either be megaloblastic or non-megaloblastic, and it could be vitamin B12 folate deficiency, or even alcoholism, liver disorders, or hypothyroidism. So we have a low patient, chronic anemia patient with a low hematocrit and hemoglobin with low platelets and WBC. In that case, on examination, if we have a splenomegaly, our clues will be that the patient has got an hypersplenism. It could be due to portal hypertension or liver disease or any lymphomas or SLE. Suppose he doesn't have a splenomegaly, it could be a multiple myeloma or a aplastic anemia. What if a patient has got a low hematocrit hemoglobin but increased platelets or WBC? It could either be a leukemias, it could be either acute or chronic leukemia or myelofibrosis, or it could be increased platelets where we have essential thrombocytosis and myelofibrosis. And if it is increased platelets, if it is low hematocrit with an increased reti count index, if there is a hemolysis as evidenced by increased bilirubin, LDH, and haptoglobin, we do a peripheral smear and showing a fragmented RBCs, we know it is microangiopathy. It could be any autoimmune microangiopathy or a TTP or HUS, or if there is no hemolysis, it could be only a blood loss. If there are no fragmented RBCs, we do a immune test, that is a direct Coombs test. And if it is positive, we know it is autoimmune hemoglobin AIHA. And if it is negative, we know it is a membrane defect. What if it is normal? And it is macrocytosis, we know it could be a folate deficiency, as seen in megaloblastic anemia. Or if there is no drugs, then it could be myelodysplasia, hypothyroidism, or congenital anemia. If it is microcytic, then we have either iron deficiency or a thalassemia as a differential. So I have given you a bird's eye view of the evaluation of anemia. Thank you very much again. Thanks once again to all the organizers for this wonderful opportunity.
Thank you, ma'am. Before I continue, you have a question.
Yes,
Dr. Sundaramurthy sir, he's requested you to elaborate the role of zinc in anemia treatment protocol.
Make your pardon, madam.
Zinc, madam.
The role of zinc in anemia treatment.
Is it the role of zinc in?
Zinc.
Yes, madam. Zinc deficiency can also cause a microcytic hypochromic anemia. So in that case, we might have to replace zinc. In adults, though, we don't see much of cases.
Okay. Sir has also asked about post-COVID patients, how to treat the anemia there.
Any special consideration, madam? Anything different in post-COVID patient with anemia? Any special concern?
Not much, sir. Not that we have seen. We'll have to look for their comorbidities and other medications that they are on, sir. Post-COVID patients, if they are on any other medications, then only that. Otherwise, we treat them as any other anemia.
Okay. Thank you, madam.
Thank you so much.
Ma'am, I would like to pose a question. So I had this young woman today. She's around 27. No other medical comorbidities except for obesity. Her B12 and D were quite within normal limits. Very occasionally takes alcohol, but she claims that there has been a sudden drop in her hemoglobin. No active bleeding, periods are regular, as in the flow has been normal according to her. But within a gap of 3 to 4 months, she says, because I redid the blood tests, she had undergone an ankle surgery recently, before which she says her hemoglobin was 13.1. And today when I saw it, it was 10.5. So I was just wondering how I could go about this.
Madam, can you look for any occult blood loss, madam? GI blood loss, maybe you can do stool occult blood. And then we need to evaluate. Suppose she doesn't have any menorrhagia, madam. She doesn't have any.
No menorrhagia, ma'am. Regular
What
cycles.
about thyroid levels, madam?
Thyroid is normal, ma'am. Check.
Thyroid
Check
is
the normal.
Okay. Thyroid antibodies also normal, ma'am.
I haven't done that. I only did a TSH profile. I'll do that. Okay, ma'am. So I'll just do a thyroid antibody.
We'll look for an occult blood, madam, and peripheral smear, blood smear picture might give you some clues if she's got any other causes.
Sure. Thank you. Thank you so much. Any other questions in the forum?
Madam, can I ask one question, madam?
Yes, sir.
Okay, madam, is there any criteria, important criteria to label a patient as refractory anemia?
I think Jayalakshmi madam is dealing with the treatment. Refractory anemia, as such, we don't have any criteria. Am I audible?
Yes, sir. Yes, ma'am. Yes, ma'am.
Refractory anemia, maybe after treatment, we'll have to consider which type of anemia, and then we'll have to go in for that. I think madam is talking on the treatment of anemia. I think.
Okay. Okay, madam. Thank you. Thank you.
Thank you, ma'am. Anybody else? Right. May I continue? So thank you, Namita ma'am. That's the succinct presentation. I think you've managed to give us all the main points. You've been so sweet. You've answered all our questions so well as well. So I really thank you for allowing us to listen to your talk today. Moving forward, our next eminent speaker is Dr. S. Jayalakshmi ma'am, who has done her MBBS in the year 1990 from Keel Park Medical College, DCH in 1996, MD Internal Medicine in March 2001, and DM Nephro in August 2008. Ma'am is currently, So ma'am has moved upwards from assistant professor to associate professor to professor, currently in Tamil Nadu Government Multi-Super Speciality Hospital, Omandurar Estate. She's won various awards and she's presented a large number of papers. She's been a guest lecturer in varying CME programs. And ma'am has also had publications in an article in the IP Journal of Urology, a chapter on calcium metabolism in ICP, a chapter on renal biomarkers. And her areas of interest include hypertension, hemodialysis, preventive nephrology, and onconephrology. It's my honor to present to all of you, ma'am. Thank you, ma'am. Ma'am, the dais is yours. Ma'am. Jayalakshmi, ma'am.
Madam is still not come. I will try.
She's not here in our.
It's signed in.
She is not seen in the list.
Yeah, she's not seen here.
I'll just call her.
Madam will be joining in 2 minutes. She has some connectivity issues. She'll be joining from her mobile now. Please bear with us.
Oh, okay, okay. Or he is just login again. Meanwhile, can I say a few words?
Yes, sir.
Secretary.
Sir, please.
No. We have to improve our membership drive because no one is putting any effort. So all this while, so President Madam has got some idea. President, are you there, Madam?
Ma'am,
Unmute yourself, madam.
ma'am.
Madam, unmute.
Ma'am, gotten muted again. Vedakumari, ma'am.
Yes.
Yeah, now she said.
Okay, now you're able to hear me.
Yes. You're talking about some students are
Sir,
joining.
just joining their duty now only, no duties. So அவங்களால பேமெண்ட் மொத்தமா பண்ண முடியாது. 2 இன்ஸ்டால்மெண்ட்ல பண்ண முடியுமான்னு கொஞ்சம் நான் கன்செஷன் அவங்களுக்கு மாத்திரம் கொடுக்க முடியும்.
No problem, ma'am. We have to discuss in the
அத கொஞ்சம் ரேட் இந்த அமௌண்ட்ட கொஞ்சம் ரெடியூஸ் பண்ணியும் பிகாஸ் ஆஃப் பிசினஸ். அப்புறம் 2 இன்ஸ்டால்மென்ட்ல பே பண்ணிட்டு
ஈஸில டிஸ்கஸ் பண்ணுவோம். ஈஸில டிஸ்கஸ் பண்ணிட்டு then we'll
ஈஸியா தான். இப்ப நம்மளுக்கு மீட்டிங் இருக்குது இல்லையா நெக்ஸ்ட் வீக், அன்னைக்கு பார்க்கலாம் 12. So that's why I kept quiet. அது பத்தி
because you said the number is more.
Yeah, அது 2 வாட்டி இந்த அமௌண்ட் சொன்னோனே இது பண்ணிட்டாங்க. முதல்ல எல்லாம் ரொம்ப கம்மி அமௌண்ட்ல ஜாயின் பண்ணிருக்கோம். இப்போ now you said 21.
அதெல்லாம் நம்ம பண்ணிக்கலாம் மேம். ஈஸில டிஸ்கஸ் பண்ணிட்டு we can reduce the amount and we need more doctors
if
in the
so
association.
I can just follow up them again.
We'll discuss and
I'll try to meet them and I'll try to talk to them and find out.
Members for PPLSS and FSS எல்லாம் ரொம்ப ஜாயின் பண்ற மாதிரி தெரியல. A lot of benefits out of this schemes.
Yes.
அதையும் பண்ணணும்.
அது ஏஜ் லிமிட் என்ன இருக்கு சார்? above 50 தான் ஜாயின் பண்ணணும்.
இப்போ 55 வரைக்கும் எக்ஸ்டெண்ட் பண்ணிருக்காங்க நினைக்கிறேன். 50 FSS 1க்கு வந்து 50, FSS 2க்கு வந்து 55. I will get the details.
Yeah.
Yes, sir. It is 50 and 55. FSS 1 is 50, FSS 2 is 55.
Who are willing to join also can join. Actually, FS, yes, sir.
Humble suggestion. Nursing board is இருக்கு இல்லையா, நம்மது மெம்பர்ஷிப் இருக்கு இல்லையா, ஒரு group of people are there in nursing home board இருக்கு இல்லையா.
Yeah.
Through them, அவங்க ஹாஸ்பிடல்ல இருக்கிற டியூட்டி டாக்டர்ஸ் எல்லாம்
சூப்பரா இருக்கு. How are you?
அவங்கள இது பண்ண முடியும்.
I'm trying, sir. அதுவும் இங்க வர டாக்டர்ஸ் டியூட்டி டாக்டர்ஸ் எல்லாம் புடிச்சு போட்டு தான் இருக்கிறேன். And see some of them are temporary duty வந்துட்டு போயிடுவாங்க. அவங்க எல்லாம் கொஞ்சம் யோசிக்கணும்.
ரெகுலரா இருக்கவங்க
அதான் ரெகுலரா
கார்ப்பரேட் ஹாஸ்பிடல்ல தனியா அவங்க பிரான்ச் ஓபன் பண்ணிடுறாங்க. லைக் காவேரி has their own IMA.
ஆமா, காவேரி எல்லாரும் காவேரி MGM all new corporate hospitals they
அவங்க own IMA வச்சு மெம்பர்ஷிப் IMA இது ஆரம்பிச்சறாங்க பிரான்ச்.
ஆமா.
அடுத்த செகண்ட் கேட்டகரி ஆஃப் நர்சிங் ஹோம்ஸ்.
சார் வெளியில இருந்து ஒரு சரவணன் சார்
சொல்லுங்க.
from other IMA இதுல இருந்து ஜோன்ல இருந்து நம்மளுக்கு ட்ரான்ஸ்ஃபர் பண்ணா what is the procedure they have to do? What doctor is there?
அது பெரிய ஹெடேக்கா இருக்கு. In fact, I have 2 people coming into our branch. One is from Coimbatore.
Madam Jayalakshmi has I think joined, madam. Now.
Oh, she joined. Okay.
Madam has come.
Jayalakshmi madam is joined already.
Yeah, okay. We'll go ahead with our meeting.
Yeah.
Please, Secretary Sir.
Welcome, ma'am.
Introduce sir. Please introduce the second speaker.
Yes, ma'am. Jayalakshmi ma'am, good afternoon. It's my honor to introduce ma'am. Ma'am passed out of her MBBS in Jan 1990, TCH in 1996 of October, MD Internal Medicine from Stanley Medical College, and her DM Nephro from Madras Medical College. Ma'am is currently the professor, Tamil Nadu Government Multi-Super Speciality Hospital, Omandurar Estate, Chennai. She's won various awards, including the Young Investigator Award. She's had a gold medal. She's got a gold medal for the best poster. She's got the best doctor award from the government of Tamil Nadu in June 2018. Ma'am has presented various papers, including urinary indices and renal Doppler. She's presented guest lectures in NEFSIL in 2011, diabetic neuropathy in Chengalpat Medical College, and many other. Ma'am also has varying publications, including the IP Journal of Urology. And she's the current, like I mentioned, she holds the current position of senior consultant and professor of nephrology. Madam's areas of interest are hypertension, hemodialysis, and preventive nephrology, and onco-nephrology. It's our honor to have you here today.
காப்பி பண்ணி கொடுங்க எனக்கு காப்பி இதுல போடணும் இருவேன் இது எதுங்க Good evening. I'm very sorry if I got a bit delayed. Before I get my slides ready, I will just give a short introduction about anemia and CKD. One second. இதுல வந்து iron and CKD ல இருக்கும். அது copy பண்ணி. Basically, in CKD, am I audible?
You're audible,
Yes,
but
yes,
your
yes,
video
ma'am.
is not there.
Yeah. Now? Yes, ma'am, you're audible. Yeah. In CKD, we basically have anemia as a very common entity, and the causes for anemia in CKD are multiple. Basically, we have the erythropoietin deficiency in CKD, which is the most important cause of anemia in CKD. Apart from that, we have iron deficiency anemia, and we have anemia due to deficiency of B12. We have anemia due to deficiency of folic acid, and we also have anemia due to copper deficiency that's commonly seen in CKD. And also in patients who are on dialysis, we have, sorry, I think the not coming. We have copper deficiency also in CKD. So all these things have to be managed after a proper evaluation of the cause of anemia. So basically we have the iron studies that have to be done first. Then we will have to have the B12 and vitamin in folate deficiencies to be assessed. We'll also have to see if there is any deficiency of copper also. And in inflammation and in infections also we have in anemia and CKD, anemia especially in CKD patients. Because we have patients with intrajugular vein catheters who might get infected. And since the immunity is very much depressed in CKD, the patients in CKD on dialysis, they may also have a lot of inflammation going on, thereby causing anemia. Apart from that, we used to have anemia of aluminium over toxicity. Last one. We have anemia due to aluminium toxicity, which was there earlier, but subsequently, due to usage of RO plants, which actually remove a lot of waste from the water that is used for dialysis, we are having less and less complications due to aluminium toxicity. We will just go into the details of the newer iron therapies in CKD. Just a second. I'll be back. Just a second.
Is my slide visible?
No, not yet, ma'am.
Is it visible now?
Not visible. You are also not visible now.
I put share screen. Is my slide visible now?
No. No, ma'am. Shanta, ma'am, help her to do that.
I'm putting share screen, but it's not coming.
Now you are come.
Yeah, my video has got on. Share.
Yeah. Or Janani? Janani?
I think the share screen option has not switched.
I think
Yes, ma'am.
post she is not able to
No.
upload her post maati kodu konjam.
Problem is, ma'am.
For time being, till she uploads, let it be.
As the thing gets ready, I would like to call upon a few more things. I mean, just highlight a few more things. Initially, in the past, we just used to give oral iron and followed by IV iron therapy in people with chronic kidney disease. Oral iron therapy is usually given for people who are not on dialysis, and IV iron therapy is given for people who are on dialysis. Subsequently, we found that there is a lot of side effects for this oral as well as IV iron therapy. Many people have GI disturbances with oral iron therapy. And with IV iron therapy, we used to see, especially with iron dextron in the beginning, we used to see a lot of anaphylactic reactions. Then people had sat and developed the iron molecules so that we get better GI tolerability, better GI absorption, as well as better, less immunogenicity and more acceptability with the IV iron preparations. So we will just have a look at all these things. Apart from that, I should also tell you that there is a new molecule around which is called HIF stabilizer, that is hypoxemia inducible factor prolyl hydroxylase inhibitor. This HIF stabilizer is something which is very, very nice because it makes the EPO gene get regulated properly so that adequate erythropoietin is secreted, adequate erythropoietin is utilized, and whatever be the iron source that is available is utilized for producing red blood cells. So this is beyond this topic because we are supposed to talk about the newer iron therapies today. I just wanted to bring this to the notice of everyone that there are a new class of drugs which are in the market and we have started using them also with good results. And one such thing is actually desidustat, which we have started using. Can I share the screen now? Is it possible? Is my screen visible now?
No, ma'am. No, ma'am. Not yet. Only you are visible.
I don't know how. The share screen option is here. There is actually a green thing in the share screen.
Shanta, ma'am, guide them, no?
No, we are. We have to give you the host. We'll just get it back from. He's still holding the host in our Kanakavel. We'll just get it for you. 1 second. We'll just talk to him and get it back.
In the meantime, shall I keep presenting, madam?
Yeah, keep
Yeah.
presenting. I'll just get this to upload the slides.
So we have something called KDOCI guidelines, Kidney Disease Outcome Quality Initiative guidelines, which guide us through and through with periodic amendment and periodic updating of the guidelines. We are able to treat kidney patients, and that covers a wide range of areas such as when to dialyze the patient, how to treat various glomerular diseases, and how to look for various metabolic issues in chronic kidney disease and things like that. So we have the KDOCI guidelines, which I will highlight with regards to iron therapy in CKD. And iron metabolism in CKD is also something which I would like to highlight, because this iron metabolism is a little unique in CKD. And iron formulations, I will discuss about that. And the other medicine which I already told you is about the HIF stabilizers. As I told you, the other causes of anemia and CKD are erythropoietin deficiency, and shortened RBC lifespan is also seen in these patients, which also leads to iron deficiency, which also leads to anemia, as well as iron deficiency. And blood loss also leads to iron deficiency in these patients. So I will just give a mental picture of how iron is absorbed in a patient. Basically, the dietary iron is imported across the apical membrane. It comes in actually the ferric iron form, and that gets converted into the ferrous iron form. And actually the duodenum is the site of absorption of the iron. And using several different mechanisms, the dietary iron gets inside the cell. And after getting inside the cell, it is stored as ferritin inside the cell, or it is transported via ferroportin to the blood. Here what happens, the ferrous iron becomes ferric iron again, and this ferric iron binds to plasma transferrin. This is how the iron is transported into the blood and utilized for erythropoiesis. And we have something called hepcidin, which is a very important molecule, which actually can prevent this transport of iron and absorption of iron inside. So this hepcidin blocks iron absorption by reducing the basolateral membrane abundance of ferroportin. So this ferroportin is very important for absorption of this iron, which is actually inhibited by hepcidin. I hope you can get a mental picture of what I'm telling. We have the enterocyte in the middle. We have the gut lumen on one side where ferric iron becomes ferrous iron. And then there is also the heme iron that can also be transported inside. And this binds to ferritin. This becomes ferritin inside the enterocyte. And whatever iron that is going to enter the blood system is going to go inside as ferrous iron via ferroportin. And this ferrous iron will become ferric iron and gets into the plasma transferrin. This is blocked by hepcidin. So these are the molecules. This is the actual system that happens whenever somebody ingests iron. But then there is this hepcidin, which plays a very important role. What all it does is, from the liver, iron can be utilized by recirculation. And whenever the RBCs are senescent, iron is recycled through the reticuloendothelial system. From the liver, the hepcidin actually blocks iron utilization of iron from the liver. This hepcidin also blocks iron absorption, as I told you earlier. And this hepcidin also blocks iron recycling in the reticuloendothelial system. So hepcidin is a very important molecule which will actually interfere with iron utilization, thereby causing anemia. This is very important. And once this iron bound to transferrin gets into the blood, it goes to the bone marrow, where we have the erythropoietin secreted by the kidney acting on the EPO receptor. So this EPO acts on the receptor in the bone marrow, and the iron is utilized to produce RBCs. So this is how the iron that is ingested by the patient is utilized for the production of RBCs with the help of erythropoietin. Will I be able to share my slide now?
Not able to contact him.
Oh my God.
We're trying.
You're trying.
Shall I continue this way itself?
Yes, ma'am. Continue.
Yes, ma'am. Sorry.
No problem. It's enough if I'm clear.
Yes.
Am I clear? I mean, without drawings, I'm explaining. Is it okay?
It's okay, it's not coming. No, we can't help. We'll
Yes.
continue, ma'am. No problem.
So this dietary iron, absorbed iron, will get into the bone marrow. Thereby, with the help of erythropoietin, we have the RBCs produced, and hepcidin actually blocks the iron recycling as well as iron absorption. That is very important. Now we have two types of iron deficiency. One is an absolute iron deficiency, another is a relative iron deficiency. Absolute iron deficiency is when we have real deficiency of iron. We have the iron indices there. The real deficiency of iron is the iron itself is low. Then the saturation of the transferrin is low. Then the ferritin is also low. Everything is low in these cases. But in relative iron deficiency, we have good ferritin, but the T-sat is reduced. That means the iron is there, it is being utilized, and more iron is required. That is going to be actually supplied by, we have to give it either orally or parenterally. Then we also have to know something about the iron overload. Supposing a patient keeps on getting iron because the hemoglobin is low, it may be due to many other factors that I highlighted earlier. If we keep on giving iron alone, and this iron is not getting utilized because the erythropoiesis per se is not good, then it's not adequate, then the patient may land up with iron overload. This iron overload is going to get deposited in various organs and cause cirrhosis. If it gets deposited in the liver, it can get deposited in the pancreas. So it can actually cause organ damage if it is deposited everywhere, for which we have to give chelation therapy with the desferoxamine. This desferoxamine chelation therapy is a chapter by itself, which actually will help us in CKD patients to remove the excess iron. Just I want to tell a word about this. Now, in functional iron deficiency, as I told you, the T-sat is less and ferritin is normal or raised. Because this usually happens in inflammation, we can see that the ferritin is normal. Because in inflammation, even if the actual ferritin is less, it becomes increased and may be normal or raised. So inflammation is one of the important causes of functional iron deficiency. And ESA treatment. Supposing we start treating the patient with erythropoietin, exogenous erythropoietin, this erythropoietin will actually start using the whatever iron that is available, and this ESA treatment can lead to functional iron deficiency. We must realize this and give iron to those patients who are on ESA treatment, because the ferritin will be normal in these patients. I just want to highlight the KDIGO. KDIGO is kidney disease, improving global outcomes. All these guidelines are given, it's an international guideline, wherein we have guidelines specific for anemia and specific guidelines for iron in CKD. So when do we treat with iron agents? When do we give? When prescribing iron therapy, balance the potential benefits of avoiding or minimizing blood transfusion. Our main aim is to minimize the blood transfusion. Why should we minimize blood transfusion in these patients? Number one, by giving more and more blood, we sensitize the patient. If the patient is going to undergo transplant later, the patient might be a sensitized individual and may go in for rejection. So that may be one reason. Another reason is the blood per se may lead to iron overload, and blood transfusion may be accompanied with a lot of reactions. So all these things, we have to weigh the benefit of blood transfusion. Thereby, we should give blood transfusion only if it is absolutely needed. Then ESA therapy, erythropoiesis stimulating agents like erythropoietin, darbepoietin, all these things should also be given to these patients, but after we have given enough iron to the patient. Only then it will be beneficial. And then we should also be careful about long-term risk, unknown long-term risk of various formulations that we are going to give for this patient. So what do they say in this guideline is, for adult CKD patients with anemia, not on iron or ESA therapy, we have to give a trial oral or IV iron. And whenever an increase in HB concentration without starting ESA treatment is desired. So initially we have to give iron and see, and then only start giving ESA treatment. And for this they say that the T-sat should be less than 30% and ferritin should be less than 500. Normally we go for 200 nanograms per ml of ferritin, which is considered normal and adequate. But in CKD patients, we can go up to 500 ml. So anybody who's got a ferritin of less than 500 and T-sat of less than 30%, then these patients will need iron therapy. Am I audible?
Yes,
madam.
yes.
Okay.
Yes, ma'am. Audible.
For CKD,
Yes, ma'am. Yes.
not dialysis
Very much.
patients who require iron supplementation. As I told you earlier, the oral route of iron is preferred. And response to prior oral iron therapy should be taken into consideration before we go over to the subsequent oral therapy of iron. So we have to get a proper history to see whether this patient has actually taken adequate oral iron therapy. If not, or if you still feel that iron is not adequate, we can go ahead with the oral iron therapy. And then usually in patients on dialysis, we give IV iron therapy. For one reason, the patient comes to the hospital for dialysis, it will be easy for us to give the IV iron. And number two is IV iron is much more required in these patients. And these patients have poor GI absorption of oral iron. Thereby, in dialysis patients, we always give IV iron therapy. And guide subsequent iron administration based on HB response to recent iron therapy, as well as ongoing blood losses. Iron status test should be done and HB concentration should be seen periodically. If we are giving ESA, we have to see how the ESA responsiveness is there, and then how we are dosing the ESA, whether the patient needs any escalation of ESA dosages. Then how do we evaluate? At least every 3 months, we have to evaluate the T-sat and ferritin. So somebody comes to us, the hemoglobin that is aimed at is around 11. We don't want to go beyond 11 grams because beyond 11 grams, the patient lands up with a lot of thrombotic complications, cardiovascular morbidity is increased. So our aim is to get around 11 grams. So anybody who's got an HB of less than 11 only, we should start the therapy. And every 3 months, we have to keep checking for the T-sat and ferritin. And we'll have to decide whether the patient requires subsequent iron or ESA. And then iron status, T-sat and ferritin more frequently. For example, whenever we give an increased ESA dose, a person comes, we start giving iron therapy, then we feel iron is all well replenished, we start giving the erythropoietin. Then supposing we increase the dose or initiate a new erythropoietin, then we must check more frequently. We should not wait for 3 months because it may be too long a time. There may be under responsiveness or over responsiveness because we don't want hemoglobin more than 11 grams. We have to check them more frequently. Or when the patient has had a blood loss, then we have to check frequently because the hemoglobin would have dropped by then. And then IV iron, if we give, we have to monitor the ESA responsiveness after an IV iron. And then cautions. When the initial dose of IV iron dextran is administered, this actually was initially for the iron dextran because administered, we recommend, and when the initial dose of IV non-dextran is administered, they suggest that patients be monitored for 60 minutes after the infusion. Basically, the iron dextran was supposed to be a little immunogenic, and we had a lot of reactions to that. Subsequently, we have a new iron therapies wherein it's almost absolutely non-allergenic and the patient is doing well. But even then, we have to monitor for 60 minutes after the infusion. That is very important. And it should be administered only in a facility where we have resuscitative facilities. And the personnel should be there to evaluate and treat serious adverse reactions because still we have to have everything geared up so that we treat whenever there's an eventuality. But I should tell you, in my practice, I've been a nephrologist for nearly 20 years. I've not seen any reactions to the current available IV iron preparations, except very rarely some pruritus or some allergic, very minimal allergic reactions. So the current iron preparations are really very good. And then anybody who's got a systemic infection, we have to avoid administering IV iron because the systemic infection may get flared up. And as we told you, there'll be only an iron deficiency because then the inflammation is high. So when we go to the iron formulations, orally, I should tell you, we only used to use ferrous sulfate earlier. Then we now have ferric citrate. Then we have ferric maltol. Then we have heme iron polypeptide. Then we have sucrosomal iron. All these are newer oral preparations, which are supposed to be very good for the patients. And then we have IV iron formulations like ferrumoxitol, iron isomaltoside, ferric carboxymaltose. Then there's something very nice, the intradialytic iron formulation. We can give iron during dialysis in the dialysis fluid itself. So that is a new formulation that has come, which is also supposed to be very efficient. So what happens when you give this ferric citrate? This ferric citrate basically came as a phosphate binder. We know in CKD we have high phosphate levels and low calcium levels in the initial period. So what we do is we give calcium-based phosphate binders, which actually acts as a source of calcium to the patient, as well as phosphate is bound by this calcium salts so that the phosphate gets excreted. Later on, the patient starts having normal calcemia and even hypercalcemia. So we stop the calcium-based phosphate binders at one point of time. Subsequently, we go for the non-calcium-based phosphate binders because at that point of time, there is no need to give calcium. The calcium level is reached well and the patient maintains a good calcium level. Because if we keep on increasing the calcium levels in the blood, calcium and phosphate may precipitate everywhere and form a lot of calcifications. Then this non-calcium phase phosphate binders like 7-MR have been in routine use. They found out that ferric citrate, which is an iron citrate, is supposed to have a phosphate binding capacity. So it was initially introduced as a phosphate binder. But then they found that whatever the ferric is there, after binding the phosphate, some amount of iron is also getting absorbed. Thereby, it can increase the iron stores. And then, as I told you, it can get into circulation and increase the RBC protection. Apart from that, it also decreases FGF23, whereby the erythropoietin is also stimulated. It also increases active vitamin D3. The bone density is increased and the cardiac functional capacity, everything is increased by this particular compound. So ferric citrate has become a very important thing in the armamentarium of iron therapy. Then we have ferric maltol. The ferric maltol is another sugar-based iron, wherein we actually have ferric. Ferric iron sucrose we used to use. Similarly, we have this ferric maltol. This ferric maltol is the oral formulation which is absorbed intact. It has a better bioavailability because we have always the iron that is surrounded by a carbohydrate covering. It is intact, absorbed intactly. It doesn't undergo any modification. So the iron is not exposed outside. So it's absorbed intact. It has got a better bioavailability and the reduced GI toxicity is because the iron is not exposed. So the reduced GI toxicity, patient feels very comfortable, and it also inhibits iron-mediated lipid peroxidation and reduces oxidative stress. Because with iron, we see that there's a lot of oxidative stress on the patient. Thereby, iron toxicity can cause oxidative stress. So in maltol, this is actually inhibited. So another compound, ferric pyrophosphate, that also has a phospholipid bilayer and a sucrosomial shell. Unique structure, absorption through various means, through lymphatic system and endocytosis, everything is getting absorbed, better bioavailability and lesser side effects. So we have various oral iron preparations that are absorbed intact without exposing the inner iron core, which is supposed to be having a high redox potential. And it also has a better availability into the system. The iron is absorbed better and hemoglobin is increased. And apart from all these things, the GI tolerability is very good and the patient does not complain of much GI side effects. Going to iron preparations, we initially had the iron dextran. Then we have iron sucrose preparations. All this iron dextran is supposed to be very immunogenic or allergenic, but iron sucrose is supposed to be quite compatible and patients used to accept it very well. And we have other newer compounds like ferric carboxymaltose, ferromoxitol, and iron isomaltosate. These three compounds are newer ones where there is high stability of carbohydrate shell. There's a carbohydrate shell, as I told you, in oral iron, there's also carbohydrate shell in these IV preparations. And this prevents the release of the toxic free iron. Thereby, the redox potential is very low. So the oxidation reaction is very much less. And they're again less immunogenic and it can be administered in large quantities. For example, the iron sucrose that we used to give only 100 milligrams in every sitting. But this ferric carboxymaltose and iron isomaltose, we are giving 500 to 1000 milligram in every sitting without any side effects. The patient tolerates them very well. So it can be administered in good quantities. With just 2 injections, the patient is going to have iron repleted. There's something I told you about the dialysate iron, that is ferric pyrophosphate citrate. This is actually added, in dialysis, we have 2 solutions which are actually sucked by the machine, mixed with the RO water, and a dialysate is produced with a particular composition that we need. In this, we have 2 of the 2 solutions. One is an acid solution, another one is called a bicarb solution. The bicarbonate solution, this ferric phosphate citrate is added to the bicarbonate solution, so that small doses of iron goes into the body during every dialysis cycle. This doesn't get into the RE system at all, it gets straight away into the blood, thereby replenishing the iron stores. And it directly binds to transferrin, goes to the bone marrow and produces RBCs. So again, what I told you earlier about the new agents, the HIF stabilizers, we have roxadustat, vadadustat, and desidustat, and they are very important thing about this newer agent. Apart from the erythropoiesis stimulating agents, which everything we are giving only subcutaneous or IV, this new agent are all by the oral route. That is very important because we can give it for non-dialysis patients, and patient does not have to wait after the dialysis for getting these agents, and oral route is always acceptable to the patient. They have multiple actions. They transcript the EPO genes, they downregulate the hepcidin, and they also have a lot of role to play in the iron absorption. So this is in short about all the newer agents that we have for CKD anemia. Hope it was clear without the pictures.
Yes, madam.
Yes. Thank you, ma'am. Thank you so much.
Thank you. Sorry, I
Dr. Any questions?
Dr. Vijayalakshmi?
Sir?
Yeah, well done, well done. Very neat presentation. A small clarification regarding renal anemia. How common in male or female? Any?
Sir, actually, we see anemia equal in both the genders, sir. But
Should he take any precaution in female? Because
basically, the regular menstrual blood loss in females makes them more vulnerable for more severe anemia, sir. So we will have to tell them to tell us whenever there's going to be a increased menstrual blood loss. Replace iron orally much earlier for these patients, sir.
any role of stem cell therapy in future for renal anemia?
Renal anemia stem cell therapy, I don't see any suggestions like that, sir.
Okay, thank you, madam.
Transcription
What
agents.
about the...
Yes.
Can I ask a question?
Yes, ma'am.
When is erythropoietin indicated? I mean,
whenever we have a patient with renal failure and anemia, we have to check the iron stores. Many of them are iron depleted. So we have to ensure that the patient has got a T set of more than 30, ferritin of more than almost 200, more than 200 to 500. Only then we have to start the erythropoietin. Because replacing iron itself is good enough in a small percentage of cases. And if we give erythropoietin without repleting the iron stores, they will go in for a functional iron deficiency. So we have to check the iron stores, give adequate iron, and then give the erythropoietin.
So we check ferritin, and what is the other one you said?
T-SAT. That is, we see the iron, we see the transferrin, and we calculate the
transferrin. Oh, you check the transferrin also.
Saturation, yes, madam. We calculate the saturation.
What about the intramuscular injections, madam?
Intramuscular, we don't give any iron injections intramuscular at all, sir.
It is painful.
Iron or oral iron, sir?
Okay.
Oral or IV?
Oral or IV. Usually non-dialysis patients, we give oral. Dialysis patients, we prefer IV, but it all depends on how much iron deficiency the patient has.
So we have used iron dextron complex. I mean, as you said, there's not much of reactions we have seen. But the newer one, what is the newer one you said has come in the market?
Yes, yes, madam. The newer ions that we have are ferric carboxymaltose, which we have been using for more than 10 years now. Then iron isomaltosite. Then we have the other one is ferric pyrophosphate, madam. All these things have come, but I mean, I've used a lot of ferric carboxymaltose.
Ferric carboxymaltose.
Recently, but there was news that one particular, not a brand, but one particular batch of ferric carboxymaltose had some contamination. But by and large, that compound is supposed to be quite acceptable to the patients.
Okay.
And iron sucrose is the usual molecule that we use, madam. I didn't talk much about it because it's something which we use. It is very good. It is very tolerant to the patients are very tolerant to this. Patients are very comfortable. But only thing, we can give only 100 milligram every time. So with other IV ions, we can give 500 to 1000 milligrams.
Oh, then the newer one, you can give 500 milligrams so that just 2 sittings, iron depletion is
almost the whole iron deficiency the patient has, madam.
Oh, that is the advantage because
generally
that we used to give 100. Okay, thank you.
Madam, generally the intramuscular injection of iron itself is not in use, isn't it? Generally, not for renal patients.
Not even for others. Nobody uses it now.
Yeah, no, nowadays it's all kind of obsolete. Thank you, madam. Thank you for excellent presentation.
Thank you, sir.
Sir, can I suggest a few practical points, sir, if you don't mind?
Yes, yeah, please.
Yes. Thank you, madam. It was an excellent presentation and a nice topic, the anemia, which is a very common actual. Last 30 years, I'm practicing here. We had a lot of issues with iron. So commonest to everyone in day-to-day practice, we use iron in various molecules we use. Started with ferrous sulfate and with all newer molecule, including liposomal, colloidal iron, all sorts of iron has come. But what happens is when you monitor the hemoglobin status, the rise in hemoglobin is different with each molecule. Still, ferrous sulfate is superior. This is one. Second thing, regarding the side effects because of the iron. There may be a constipation, there may be a diarrhea, abdomen pain, all sorts of issues. Many of them metallic taste they don't take. Gynecologists are all there here, and also GPs we use these iron. Basically, I'm a pediatrician, also practicing family physician. What I found was the better the iron molecule is ferrous sulfate, and the dosage to be used is early morning, empty stomach, and alternate days iron is the therapy that is the dose we have to utilize. Why? Because you have excellently told about the epsidin molecule. The epsidin is lowest during early morning, so iron absorption is very good during at that time. All the side effects are because of free iron, because this epsidin blocks this iron, so lot of free iron is available during when you give after food or afternoon or night. So this the side effects occurs. So early morning when epsilon is low, kindly if you are going to give very successful, the patient side effect is very minimal. Second thing, parallelly after the iron absorption, parallelly the epsilon also rises. It stays for 24 hours. So only daily dosing, you'll get a side effect on the second day if you use it because the epsilon level is high. Then it decreases. So after 48 hours, once again it comes to the lower level. So early morning, alternate days of simple ferrous sulfate does so much wonders. So this one I want to share. Second thing, regarding IVIN, if as Madam told, as a specialist they are using, in case of malabsorption, you can use, but kindly avoid. The problem is I have seen almost 5 to 6 reactions in my clinic. Almost the patient died in front of me. Luckily, I had adrenaline, hydrocortisone, oxygen. I resuscitated, I saved. Still, even if I'm going to hear about IV iron itself, I feel jittery now. It's such a dangerous molecule. It should be used only in hospitalized situation. And that too, kindly use hydrocortisone half an hour before IV iron. That is very safe. And now I see a lot of prescription saying that you can put some test dose. No use. Even if you put the test dose also, the reaction occurs. If the test dose is normal, negative also, you will be getting the reactions. That is another point I want to share. And third is being a pediatrician, uh, please kindly don't use any iron syrups. It is causing lot of staining of the tooth. Crush the iron tablet and you can give it along with juices. As you know, that citric acid, that is good absorption with iron. So these three things for a general practice, I thought I want to share. Thank you, madam.
Very nice. General practitioner.
Thank you, Dr. Suresh. Thank you. Others view?
No, like this, we require input from the general practitioners because they are the ones who are really dealing with cases. It was very nice.
But iron capsule per se can cause gastric irritation. Dr. Suresh?
That gastritis
Yes, sir.
with iron.
Actually, the beauty is for one
Hmm.
patient, hemoglobin was 6. What we tell is below 7, there will be lot of CCF will be there, heart failure and all. Most of them are compensated by at 6 hemoglobin. Exactly alternate day regime, 3 months, it came up to 10, sir. Simple iron sulfate.
So if they develop gas, do we give them
Nothing, no gastritis. The gastritis is all because of the extra free iron only. During the morning, there will not be any free iron. It will be totally absorbed.
Okay.
That is the beauty of epsidin molecule, which madam has mentioned. It's the blocker of iron. That epsidin only causes all sorts of irritation.
in pregnancy?
How do you give
sorry.
No, 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 please. No, no. How do you give the IV iron, Dr. Suresh, in the clinic?
Yeah, I used to give, sir, because whenever there is a less hemoglobin,
No,
like
we
6
give.
and 7,
Yeah.
with NS
We give
100
with
ml,
100 ml NS or
100
45
ml
minutes we
NS
give.
for half an hour to 45 minutes, we used
Yeah.
to give it. And as madam told, for 1 hour, we used to observe. But within
Okay.
15th or 20th minute, after starting the IV, when few drops enters itself, I go to the OP and start my first patient means. Suddenly, the entire team will come, sir. அப்படியே நிக்கிறாங்க மூச்சு நின்னுட்டு. அதான் அந்த 5 பேஷண்ட் இன்னைக்கு வரைக்கும் நான் அவங்க வருவாங்க இப்ப கூட கிளினிக். அவங்கள ஃபர்ஸ்ட் நான் கால் பார்த்துட்டு தான் பாடி மீதிலாம் நீ ஆவியா இன்னும் உயிரோட இருக்கியா இல்லையா?
Which formulation do you use, sir? Which IV formulation, sir?
That was
iron
sucrose, madam. Iron sucrose.
The trade name also you can tell.
I had this issue, but of course, that another thing is that MCure company products, 2 deaths have been reported. So be very careful. If at all want to use, Ferrium is ideal.
Ferrium. This Orofer FCM.
Orofer FCM is good, sir.
Madam,
I used to give it test dose. I used to give it test dose on ampule.
Okay.
Ampules are coming. So I used to give that.
Jayalakshmi, madam, you are talking about some particular brand name which is probably not good.
Yeah,
Can we know that? It's a closed group, we can disclose that name.
Recently, only one particular company, I think it's MCure only, sir. One particular batch had the problem, sir, because MCure FCM we've been using for more than 10 years.
Yeah.
I've for so many patients, nothing has happened. But one particular batch had a problem, sir, recently.
Oh, batch, okay.
That particular batch at
Because
some time,
we've been using, touchwood, there is no such event so far. So that's what little scary Suresh told.
And it's not needed, sir, actually. For madam practice, it's needed because there's a lot of systemic issues. We all use only for if it is less than 6 and all we are using. We can just, you all start this regime, you will see the successful result.
Yeah, this is actually a dicey usage of IV iron. Always it's dicey situation. If it is less than 5, we are going to transfuse blood. If it's between 5 and 8, so that we can manage with immediate effect. We can manage with IV iron. So that's a situation where you get all these reactions and all that. Whether a patient is having failure due to anemia or problem due to this drug, we don't know on that situation.
Sir, what is that latest preparation where you add 500 milligram, so that just 2 IV infusion is enough? That latest drug.
that is
The preparation.
Preparation.
Free carboxy maltose.
Free carboxy?
Ferric,
FCM, madam.
FCM. Okay.
FCM, ferric carboxy maltose.
First I used to get test dose there. Ampules are coming, 2 ml. Then I give that FCM, 10 ml vial. No reactions, by God's grace.
But very expensive, ma'am.
You need not give those, but we actually set up the drip and give a few drops IV and then watch.
That is better.
Then only we go ahead.
Test dose is a waste.
What is the hemoglobin level for fitness for surgery? Am I audible? What is the hemoglobin level fitness for surgery?
11, 12. More than
if
10.
it is,
no, sometimes
if it's not an emergency, we can take up the case. If it is more than 10 grams of hemoglobin. If it's an emergency between 8 and 10 with a reserve unit, you can take up for surgery. If it is less than 7, better to give blood and take, or on-table transfusion also may be necessary for some cases.
PCV.
What is it?
PCV, packed cell volume you give.
Yeah, or PRBCs, yes. Packed red blood cells.
Thank you, ma'am. A very interesting discussion, excellent presentation. Thank you so much for your time. I request Dr. Mangai ma'am to give us the vote of thanks. Ma'am?
Dr. Mangai is mic is muted.
Yeah, she's there. She's there. Mangai,
Yes, is there.
unmute yourself.
Unmute, doctor. Unmute பண்ணிட்டு பேசுங்க.
Unmute பண்ணுமா. Mangai, unmute.
Yeah.
Now I'm audible, ma'am?
Yes.
Yes, ma'am. Yes,
Good
ma'am.
evening to everyone. It gives me immense pleasure to propose the vote of thanks for today's CME program on anemia. First of all, I wish to thank the President of the IMA Chennai South, Dr. Vedikumari Madam, the Secretary, Dr. M. Kanagavel, and the Joint Secretary, Dr. Janani, for conducting today's CME program. And a sincere thanks to the North Zone Vice President, Dr. V. Saravanan. Thanks to both the speakers for today's program, Dr. Namita Narayanan and Dr. Jayalakshmi. Both the speeches were it was a wonderful speech, very informative and educative. I want to thank a special thanks to the members and all the seniors who had attended today's CME. Thank you, one and all.
Thank you, madam.
Thank you. Thank you.
Thank you, Jayalakshmi. Thank you.
Thank you.
Can we
ma'am.
all
Thank
stand?
you.
Ma'am, do we?
Very interesting. Are we having a EC meeting on 13th, sir?
Yes.
Yes, sir.
Yes,
Yes, ma'am.
Yes, ma'am.
Yes.
Tuesday, 3
Tuesday,
o'clock.
Tuesday. Girishwari.
Lot of things to be discussed. And kindly attend,
Being
madam, in
elect
person.
president, please make it possible, ma'am. Tell Sarvan sir, tell her.
Madam,
She's the elect. No, she's the elect president, so she has to attend the EC meeting positive.
Mama.
Yeah, sure. Hereafter, at least for 1 year, she will be always there. Anyway, we'll meet up on 30th.
Thank you.
Thank you.
Thank you.
Thank you
very much.
Who is going to close?
Next one, anthem போடுறீங்களா?
Huh?
Next one, anthem வேணுமா?
பாடிடலாமே. பாடிடலாம், நம்மளே பாடிடலாம்.
நம்மளே பாடிடலாமா?
Oh, yes. ஆரம்பிங்க. ஜனகணமன அதிநாயக இன்னும் எல்லாரும் சிங்க்ரனைஸ்டா விட உத்கல வங்க விந்திய ஹிமாச்சல யமுனா கங்கா உத்கல ஜலதிதரங்க तव शुभ नामे जागे तव शुभाशिष मागे जागे तव जय गाथा जनगण मंगलदायक जय के भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे सिंक्रोनाइज्डाவே இல்ல.
Thank you.
Thank you all for joining.
It is gone more than 52 seconds.
ஆமா.
Almost slow, dragging.
ஆமா.
Usually it should be within 52 seconds.
ஆமா.
Anyway, thank you, ma'am. Thank you so much. Bye.
Thank you.
Thank you, sir.
Yes, thank you.
I think Anakavel has to close. Yes. OP closes. Really? Leave meeting.
Leave போட்ட
ஒன்னு ஸ்டாப் பண்ண முதல்ல வணக்கம் லீவ் மீட்டிங் ப்ளஸ்